Esta es del Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate. This is the California State Senate.
This is the California State Senate.
Esta es del Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 So I'm going to call to order this hearing of the Senate Select Committee on Asian Pacific Islander Affairs. I want to welcome everyone here. My name is Dr. Richard Pan. I'm the senator representing the 6th District, including Sacramento, West Sacramento, and Oak Grove. And want to welcome everyone to actually the first hearing of the API Select Committee. Today we're going to be addressing issues around health disparities, and particularly halting deadly diseases affecting our Asian Pacific Islander communities. And so I'm really thrilled to have a wonderful panel of people. We'll be talking about particularly infectious diseases and cancers that affect the Asian Pacific Islander community. As this is the first hearing, I just want to begin by saying that as a member of the API caucus, that the API community is one that has, of course, a long history here in the state of California. We're a community that is actually very diverse. If you think about it, when you say Asian Pacific Islander, Asia is the largest continent. The Pacific Ocean is the largest ocean in the world. And in fact, most of the world's population actually lives within the confines of Asian Pacific Ocean. And so, but yet, at the same time, we have many commonalities here in, as we came to, from wherever we came from to the state of California. And so we want to explore those through the Select Committee and also identify what are specific policy issues that are affecting Asian Pacific Islanders, recognizing both our commonalities and our diversity. So again, today we're going to be addressing many of the health issues, and I want to again thank my colleagues as well for being here. And so I want to welcome Senator Leno. Thank you so much for being here. And also, did you want to make some opening remarks? And invite him to make some opening remarks as well. So again, thank you and welcome. Senator Leno.
Thank you, Senator Pan, not only for convening the Select Committee, but also for inviting me to be on it as an honorary member of the API caucus. I am pleased to join you here today, and I want to welcome everybody, not only to the 11th Senate District, but of course this new neighborhood in the district known as Mission Bay. And just to give you a little context, I was just remembering as we were parking that around 18 years ago when I was on the County Board of Supervisors, I cast votes to approve the necessary permits for the original construction of everything that you see around here. And it is extraordinary what has been developed then, not only in terms of basic infrastructure and the gardens and parks, and of course all of the buildings and the new hospital, and more is still under construction, but the international talent of professionals and researchers who are drawn to this extraordinary collaboration between public and private sectors. And the world will be changed as a result of the discoveries that are being made here and will get to market in years to come. So it's a very exciting accomplishment, and to think this has all happened in the span of one generation. So I'm especially pleased to be here for this hearing because, well, clearly, more than a third of my district is API, and so any health issues that affect them are affecting the entire community. But also, the need to address a pressing issue, first and foremost, we have to identify it, name it for what it is, recognize it for what it is, and then engage community partners to begin looking at how we can respond to it, and respond to it in a culturally sensitive fashion so that those we need to hear the message can hear it, that it is delivered in an appropriate way. And so I know those are many of the issues that we're going to be addressing here today, and the lineup of professional voices is very impressive. So I think with that we should begin.
Thank you so much, Senator Leno. And again, I too want to thank UCSF and the Mission Bay area for having us at their facility. So I would like to start off with first an overview. I'm very pleased to have my good friend and former colleague at UC Davis, Dr. Moon Chen, who is also the principal investigator for the National Center for Reducing Asian American Cancer Health Disparities, ANCARD. Dr. Chen.
Thank you so much, Senator Pan and Senator Leno. This is a privilege to be here. Could I get some help on turning on my slides, please? And I also want to apologize ahead of time. I didn't realize how busy this area is, and I need to leave at 1:50. So you're going to get the equivalent of a motion picture. I'm the first presenter. Someone has my slides here? Okay, there it is. Yes, that's correct. That's the one. Okay, that's it. Okay, good. All right. Thank you very much. Well, these are the questions I want to try and get answered by the time we're done. I want to show how the cancer burden affecting Asian Americans, Pacific Islanders is unique, unusual, and unnecessary. I want to talk very briefly about the commonalities between Hep B and HPV, and then how the approach to H. pylori is really the same as the previous thing. The bottom line is what Benjamin Franklin says: an ounce of prevention is better than a pound of cure. So I represent ANCARD. So the first thing I want to say about the cancer burden is we are the first U.S. racial group to experience cancer as a leading cause of death. We used to be the only one, but just in 2012, Latinos also experienced cancer as a leading cause of death. American Indian tribes also experienced cancer as a leading cause of death. And so, in a sense, that makes us the model minority, right? We're leading the way. Our cancer burden, though, is unusual. Unlike most other Americans who experience chronic forms of cancer, such as lung cancer and colorectal cancer, our cancers are those that disproportionately affect us because they're of infectious origin, such as Hepatitis B-related liver cancer and HPV-related cervical cancer. But the good news is it's unnecessary. It's unnecessary because uniquely, the two cancers that we're going to focus on, Hep B related liver cancer and HPV, are vaccine preventable. How we wish in the cancer world that there were more cancers that would be vaccine preventable. So it's unnecessary. All right. So here's the shocking news. Everybody knows about lung cancer and knows that this is the most deadliest of cancers. But liver cancer now is the world's second deadliest cancer. And just as cigarette smoking is the key to addressing lung cancer, hepatitis B is the way to address liver cancer. And I'm so glad that San Francisco is the world's famous city for leading the charge against Hep B. All right, so just to put things in proportion, we are 6% of the population, but more than 50% of the liver cancer. And the reason is this: where we're coming from in terms of lands of origin. And just to put it in perspective, liver cancer is a disease that disproportionately affects all peoples of color. So what we learn in the API community can be applied to American Indians, Hispanics, and blacks. This is in a sense a perfect platform for addressing a cancer that's number 2 in the world and that disproportionately affects all populations of color. This is true not only for men, but also women. And noticeably that American Indian women are the ones that experience liver cancer the most. Okay, so I want to talk about disaggregation very briefly, and I just want to highlight for you, compare the non-Hispanic white rank orders for cancer with, first of all, the Chinese, and look at the fact that in the non-Hispanic whites, none of the cancers are of infectious origin. but Chinese. Liver is number 2. So if you look at it percentage-wise, that's almost like the prostate cancer. You've heard so much about prostate cancer. It's there. The Filipinos, liver cancer is number 3. Japanese, not a problem right now. Korean. And so I just want to provide you with this background to show that liver cancer and cervical cancer, stomach cancer are the cancers that are in our top 5. And so it's really commendable that the Senate has chosen to focus on this, because not only is this a winnable cancer because it's vaccine preventable, but it is so important. Okay, so I'm going to skip this and just show you that this is the evidence in Taiwan that vaccines really bring down the new cases of liver cancer. All right, now let me turn quickly to cervical cancer. Among all U.S. racial ethnic groups, Asian Pacific Islanders, and specifically Vietnamese, women have the highest rates of cervical cancer, 5 times that of whites. Now, if we were the noisy minority, you'd know about it more, but we don't, and that's a cultural issue that we need to address. Okay, so the next topic, H. pylori, going very quickly. All the evidence to date says that while this is a very important cancer, now it's like the number 3 cancer in the world in terms of deadliness. There's really not much we can do about stomach cancer and liver cancer in the United States at the present time. In fact, CDC does not advise against screening like they do in Japan and Korea because of this. But the nice news, just like Hep B and HPV are vaccine preventable, while we don't have a vaccine against HPV, the issue is the same, prevention. And in this case, it is to limit the amount of kimchi you eat, because pickled vegetables is the principal culprit that has H. pylori associated with it, and so that's the news about this. Now, the other good thing about it is that the way in which the most effective way right now to prevent yourself from getting stomach cancer is smoking cessation. So it all relates, okay? And so now just going very quickly into HPV vaccinations. We know for adolescents, the uptake rate for diphtheria and pertussis, 86% of the adolescents have that disease, vaccine, meningitis, 78%. But look at the disparities for HPV, 62.8 and 49.8. And so, again, why should these vaccines that are appropriate for this be anything less than what is expected for DPT and meningitis? In fact, for Hep B, the rate is around 88% or 90%. So let me say this is an area that we need to change the message, and the message is this: cancer prevention is the way to go. In fact, the data and the literature all says that if the clinicians say that I want to give you a vaccine to prevent your child from getting cancer, that is the most compelling message, and that's been verified by both parents and providers that is the message that needs to go. Okay, so I said something about this. So in conclusion, these are the questions I tried to answer, and I just want to leave you that again, the message is an ounce of prevention is better than a pound of cure. This is just my view. I'm a moon looking at the Earth, and that the longest journey begins with single steps. I'm sorry I have to leave now. So.
Thank you so much. Well, so thank you so much, Dr. Moon, and we will actually be delving into 2 of these in much more depth. So let me bring up our next panel, which is on hepatitis B and liver cancer risk. We're pleased to have Dr. Stuart Fang from the Chinese Hospital and Arcadia Kolchak, Executive Director of San Francisco Hep B Free. So if you can come up. I think that as they're setting up, certainly hepatitis B is endemic in Asia and is a condition that as Dr. Moon mentioned, is now preventable through vaccination. In addition, of course, there's more work we need to do to help both screen and identify and treat people who are maybe Hep B carriers, and also and to prevent progression to liver cancer. One of the things, since we were talking about vaccinations, I do want to briefly mention before they begin, is that when we had our discussions about vaccination, when I carried a bill last year, some people said, why should we immunize children against hepatitis B? After all, they're not going to have sex, they're not using drugs. Why should children have to be immunized against hepatitis B? There's also some comments that if a child has hepatitis B, why should they be in our schools to infect our kids? So unfortunately, in some senses, the subtext is that why should Asian children be allowed in our schools if they might have hepatitis B? So I hope that we will address the issue of hepatitis B and cancer risk, and let's talk about some real science about really what truly are the risks for hepatitis B and what can be done about it. So again, I want to welcome our panelists, and then actually I know that and then I'm looking forward to also some questions afterwards as well. So thank you and welcome.
Thank you. Thank you, Dr. Pan, Senator Leno, and UCSF for hosting us. So what I'm going to do is just go briefly over some fast facts about hepatitis. As you know, there are three major types, A, B, and C. So that's the ABCs of hepatitis. Hepatitis A, as you know, is from contaminated food. It's short-term, and basically it resolves by itself. But the other two, hepatitis B and C, what happens with that is it's passed on through blood. It can become chronic, but Hep C, the difference is that it can be cured at this time. Currently, there's only treatment for hepatitis B. Hepatitis B then becomes a lifelong infection. Again, B and C can be transmitted through blood and other body fluids. And the result is it can develop into liver cancer and eventual death. So with hepatitis B, just a quick review of the liver and what it does. It removes waste and harmful chemicals from the blood. It helps to fight infection. It stores nutrients and vitamins. So when we have liver infection, hepatitis B can cause severe damage to the liver. So any changes you have in the liver, it can develop into cancer. But unfortunately, hepatitis B is known as a silent killer. So sometimes you can just advance without going through the process of fibrosis or cirrhosis. You can have inflamed liver to liver cancer without any signs or symptoms until the liver cancer appears. Unfortunately, without treatment, 1 in 4 hepatitis B patients will develop liver complications and cancer. If we look at the worldwide distribution of hepatitis B, you can see in the dark blue areas, those are areas with high incidence. And so what we did here in San Francisco was to make sure we want to screen all high-risk immigrants and high-risk population. And that's according to the CDC guidelines. So we didn't just arbitrarily say, we're going to screen all this. But we have the support of CDC. We also have support of the USPSTF in order to screen high-risk patients. So in America, you have 1 in 12 foreign-born Asian Americans who have chronic hepatitis B. So what is hepatitis B? Well, hepatitis B, you have over 240 to 300 million people worldwide who are chronically infected. In the US, you have 2 million people. So between 10 to 30 million new infections occur every year worldwide. And that's because it's passed down. The number one way that Hep B is developed is from mother to child during birth and exposure. As I said, it is a silent disease. It can lead to liver cancer without any signs or symptoms, and it causes up to 80% of liver cancer. So the number one cause of liver cancer in the world is hepatitis B. And among the Asian and Pacific Islanders, we're impacted the most. In San Francisco, our population is 37%. San Francisco has the highest incidence of liver cancer in the United States. Hepatitis B is preventable with a vaccine, But unfortunately, it's not often addressed in the Asian community because of a lot of stigmas. And I think Dr. Pan alluded to those stigmas. You know, if you have hepatitis B, why is a kid in school? If you have hepatitis B, I don't want my kids associated with you. In China, these stigmas, you can be kicked out of school. You can lose your job in China. But with Sam So of the Asian Liver Center at Stanford, he's done a lot of work in China where he's taught the government about hepatitis B, where, hey, it's okay to be in school because if you're low risk to transmit, you're low risk from developing hepatitis B. So the impact for hepatitis B, that it's a heavy burden among Asian Americans. It accounts for 2/3 of the chronic cases worldwide. In the US, it's approximately 0.4%, but 1 in 12 Asians, so that's 8%, are chronically infected. So there is a big disparity here among Asian Americans. So hepatitis B, I think, can be safely said is the largest and greatest Asian health disparity in the United States. So this is why we're here with SF Hep B free. So Asian Americans are nearly 3 times more likely to develop liver cancer versus the Caucasian population. So we want to talk about screening. So as you know, CDC came down with guidelines a few years ago in terms of who should be screened. And their recommendations along with the USPSTF is that anyone who has immigrated from a high-risk country should be screened. So 2 out of 3 Asian Americans with hepatitis B do not know they're infected. So that's why the urgency to screen all Asians. And it's a very simple test. The new guidelines from May of 2014 with the USPSTF, it says that the recommendations are to screen hepatitis B for high-risk patients, and those are Asians. And what do we use? Well, how do we screen for Hep B and what are their tests? It's very simple. You want to use surface antibody and surface antigen. So this is an algorithm in which we sent out to every primary care physicians a few years ago in San Francisco, and we developed a clinician's honor roll. So from this, you have your 2 simple tests and your results. If you're negative, you should be vaccinated because this will protect you. So in San Francisco, we also have a lot of interracial marriages. So if you marry somebody who's an immigrant from China, and they're chronically infected, you will get the disease. So it's important, if you get vaccinated, you will be protected from it. If you're negative antigen and positive antibody, then you've had the protection. So here in the United States, a lot of the youth are already vaccinated for Hep B, so they're protected lifelong. Anybody who goes in the medical field, whether it's pharmacy, dental, or medical, they have to have the Hep B vaccine. And then if you're antibody negative and antigen positive, so these are our chronically infected patients. So these are the ones we want to make sure are linked to care and that they have surveillance. So every year they should see their physician, have an ultrasound done, because you want to make sure that they don't go on to develop cancer. Because as we said, 1 in 4 chronically infected individuals will go on to develop cancer if untreated. And if it becomes untreated, then it's everybody's issue and problem to deal with it. So in terms of advances in care, we have no way currently to totally eliminate Hep B, but hopefully over the long term with the vaccine, with monitoring people with hepatitis B, we can eradicate it, such as smallpox. Incidentally, the Hep B vaccine is the first anti-cancer vaccine, yeah? It came out before the HPV vaccine did. So with hepatitis B, again, it's treatable, not curable, but I understand there is a lot of research in terms of being cured from hepatitis B. So a few years down, we should have a new drug which would be able to cure hepatitis B, and it won't be a lifelong sentence for taking the drugs because it is pretty expensive. The number 1 disease in the United States for health expenditure is diabetes. So at Chinese Hospital, we have our own health plan, the Chinese Community Health Plan. So our number 1 expense is actually hepatitis B, okay? So it is important. So with that said, it's important that hepatitis B can be a managed disease, and it's preventable with the hepatitis B vaccine. Thank you.
All right. Hello, everybody. My name is Arkady Kolchak, and I'm the Executive Director for San Francisco Hep B Free. I'm here today to share a little bit about our organization and our efforts here in San Francisco to promote education among hepatitis B and encouraging screening and vaccination. San Francisco Hep B Free is a private-public partnership that was founded back in 2007. I'll go into a little bit more detail about the other organizations that we've been partnered with. This is our 9th year. We're very excited to announce that next year is our 10-year anniversary, and we have continued to make sure that we push forward with that goal of making San Francisco the first city and county in the nation to be free of hepatitis B. So in order to go over how our efforts have been reaching out to the community and primary care physicians, I like to use the spectrum of prevention. We'll be starting with the strengthening individual knowledge and skills, going all the way up to influencing policy and legislation. To begin, strengthening individual knowledge and skills. The way that we did this was early on in the campaign, we established speaker training sessions. So we brought together a lot of members in the community that were interested in learning more about what hepatitis B is, trying to arm them with the knowledge, skills, and tools necessary in order to go out into the community and provide this information to their friends, families, and other individuals. Through partnership with the Stanford Asian Liver Center, we created Team HBV chapters at local high schools and universities. These are little, essentially, clubs at these high schools and universities where like-minded students learned about hepatitis B and engaged their student body. During Liver Cancer Awareness Month, such as October, or during World Hepatitis Day on July 28th, they were to organize special functions on campus to make sure that people get screened and educated about hepatitis B. We engage people at various health fairs that we conducted and are a part of throughout the year. Promoting community education. Now, the way that we did this was through PSAs on the radio and television. We build relationships with media outlets, and these were ethnic-specific media outlets. And one of the benefits of this, because this is such a huge issue in the Asian Pacific Islander community, is being able to reach out language-specific all across all the marketing channels. People may not read the newspaper, but what they do is they do listen to the radio. And so we are able to target each of those avenues and educate people and provide additional information about the efforts that we're doing, locations where you can get screened. We built partnerships with the San Francisco Giants and the Golden State Warriors. We've hosted special events during Asian Heritage Month. This is a great way to educate tens of thousands of people, not only in the stadium, but those that are watching on television. Other mass marketing efforts, such as the Which One Deserves to Die campaign that got huge attention several years back. And also through the support of local elected officials that are willing to help us engage the general population. Thank you very much, Dr. Pan and Senator Leno. Educating providers. Now, this is a component that we recognize was a huge need. The primary care physicians did not know too much about what the needs of hepatitis B were. They weren't able to identify that, oh, if a patient comes in that's from the highest risk population, they should be making sure that they've been screened and vaccinated. So we decided to move forward with something we call the Clinician's Honor Roll, and this is something that Dr. Fung had just mentioned. What we did was we partnered with the San Francisco Department of Public Health and Asian Week Foundation over here in San Francisco to come out with a letter that's an acknowledgement and a statement. These are the issues with hepatitis B. Anytime you see an individual from this high risk demographic, you need to make sure that you're screening and double checking that they've been screened and vaccinated. And if they haven't, to recommend those too. And so we've been able to educate over 1,200 primary care physicians in San Francisco since we launched. And this was launched, Dr. Fung, I believe, is in 2010, correct? Yes. So this is approximately 90% of the primary care physicians in San Francisco at the time. Fostering coalitions and networks. And so as I mentioned, this is a private-public partnership, San Francisco Hep B Free. So we've been able to partner with the Stanford Asian Liver Center with Dr. Samuel So, the Asian Week Foundation with Ted Fang, the San Francisco Department of Public Health, and Chinese Hospital, thank you, Dr. Fong, and State Board of Equalization member now, Fiona Ma, who started with us when she was on the Board of Supervisors for the City and County of San Francisco. These individuals were incredibly helpful for this organization to develop into the success that it is today. Those networks all coming together, being able to gain access to all of those individuals' networks has been extremely instrumental in helping us gain access and being able to educate the community better. We've partnered with other community leaders, nonprofit organizations, and now we're working on partnering with local businesses to further get out the word. Changing organizational practices. Again, this ties in with the clinician's honor roll. We've worked to change the primary care physician's practice, encouraging them to make sure that these individuals in the high-risk population have been screened and vaccinated. We've worked very closely with the Hospital Council, which has been extremely instrumental in making sure that we've been able to leverage our connections with local community hospitals and clinics to make sure that they're offering services that the community needs. That means free screenings before the USPSTF guideline and free or low-cost vaccinations. We're identifying this need. We're being able to provide it now through the help of the Hospital Council. And finally, influencing policy and legislation. So we've had many champions throughout the years that we've been doing this work over here. And one of them has been Congressman Mike Honda. He was also one of the founders and now co-chair of the Congressional Hepatitis Caucus. State Board of Equalization member Fiona Ma, she has been incredibly instrumental as well. She's also chronically infected with hepatitis B. She comes out to a lot of our functions and shares her story very openly. And now we're working on a new initiative called the San Francisco Business Initiative, where we're interacting with small and large businesses across the city. And one of the things that has come out of this, because we have done all these mass marketing campaigns throughout San Francisco, actually, that have gotten attention across the nation, including the Which One Deserves to Die campaign, but we're still missing people. People still don't understand what the difference is between hepatitis A, B, and C. They don't understand that this is something that is preventable. This is something that is treatable. So we've been able to gain access into the small businesses and large businesses of San Francisco. We've directly interacted with over 500 of them. And one of the businesses has been so kind and interested in this effort that we're doing, where we're going in and educating their employees, that they've granted us access into their human relations department. And they have enacted policy change where the language states now all new hires are recommended screening and vaccination because they can't require it, unfortunately, but they're also including health information. So they're giving those brochures into all those new hire packets, because that's when people pay attention. They look through all the information when they first start. And it's a great way for us to be able to get out additional information and encourage people to get out and get screened and vaccinated. Thank you.
Well, thank you. Thank you so much for your presentations. I do want to point out we're going to have you back up here when we have a discussion on strategies for prevention, screening, and treatment. But before we do that, I must see, Senator Leonard, did you have some questions for the panel?
Sure.
Okay.
Thank you for the informative presentation, also for the great work that you've been doing. One question comes from Dr. Chen's presentation. I'm not sure if you'll have a response. With regard to the suggestion that kimchi intake be limited, how much of it is based on diet, and how do we know that? And what other factors are there in the spread of the fact of and the spread of the virus?
Well, I think when Dr. Moon referred to kimchi, it was regards to H. pylori. So this is a bacteria that resides in the stomach. And so when there's overgrowth of this bacteria, it increases your risk of developing stomach cancer. And so I'm not sure how it works, because I just heard it first time today about kimchi and H. pylori. So I'm not sure what the chemical balance is there, but it may alter the balance where H. pylori can
So it's a
overgrowth.
contributing factor.
It's a contributing factor, yeah. So I think in medicine, what we tell people in terms of ice cream and kimchi and rice and carbs is moderation, yeah. You don't want to overdo it, but if it's in moderation, then it should be okay. He didn't say cut out kimchi. He said limit your intake. So that's an important point, I think.
Maybe a good analogy would be cholesterol in Western diets.
Correct.
Right, for heart concerns. And then there was also mention on one of his screens, but I don't think he called it out, or it might have been yours, that I think it was hepatitis B is passed from mother to child in the womb?
On exposure on birth, yeah. So what happens is the three common ways that hepatitis B can be transmitted. One is birth, so that's the most common. So that's from mother to child at birth. Because what happens is the blood, if the mother is chronically infected, the virus is in the blood, so it gets transferred upon birth because of all that exposure. Yeah. The second way, so you think of BBS, the second most common way is through blood. So if you're IV drug abusers and you're sharing needles, such as HIV, you can get it. And it's important to note that hepatitis B is actually 100 times more virulent than HIV virus. Okay. And the third most common way then is sex, because probably in med school a long time ago, you're taught that hepatitis B was actually an STD, and it still is.
I know that we've ended pediatric AIDS in San Francisco as a result of our needle exchange programs. Have those programs lowered the incidence of Hep B at all?
I haven't seen any studies to that because I'm not sure if hepatitis B was really studied with the needle exchange. I know HIV was, but I'm not sure about hepatitis B.
And then there also might be a disproportionately, I'm just guessing here, excuse me if I'm wrong, lower incidence of intravenous drug use in the Asian API community than in other communities.
I think percentage-wise it is much lower, yes.
Yeah. And with regard to the mother and birth, if she's chronically infected, clearly there's no vaccine that can benefit her. There's nothing you can do for the yet unborn child.
Just to go over Fiona Ma's story. So Fiona Ma is chronically infected because when she was born, there wasn't the state regulation and we didn't have the knowledge about screening all mothers. So currently in California, all mothers are screened for hepatitis B when they're found to be chronically infected. So at birth, within the first 24 hours, the infant is given a HBIG, which is immunoglobulin, and then started on the 3 series of hepatitis B. So Fiona's sister, who was born 10 years later, after
benefited from all that.
Benefited from all that.
And so she is not chronically infected.
She's not chronically infected.
This leads into my next question. With regard to HIV and likelihood of transmission, there's the ability through medication to lower the viral load to such an extent that it's unlikely that that person is going to be at high risk of infecting someone else. Can the same be said through medication for Hep B?
Yes. So there are some cases where you find out that the mother is a chronic carrier, that means a positive antigen, and they do to give birth, and the baby or the infant is given the HBIG, started on a 3 vaccine, but still is tested positive and is chronically infected with hepatitis B. So they found out that that's based on the viral load.
Of the mother.
So it's important to understand that when you identify and screen mothers for hepatitis B, you also want to do a DNA quant, which means you want to know how much DNA is in her blood. So if you can suppress that viral load, then you decrease the transmission also.
Right. And this may be a question for Mr. Kolchak. How is are you calling it getting to zero? I know we talked about getting to zero and Hep B free. Are we making significant progress? Because, of course, we don't have the benefit in HIV of a way to prevent through inoculation. But how are we doing on the Hep B side?
So some of the recent things that have occurred, actually about 3 years ago, we did do, was it 4 years ago actually, with the CDC screenings? We did, 3 years ago, we did 10,000 screenings in 2 years. So since the start of our organization in 2007, we've screened over 20,000 people in San Francisco. The Department of Public Health in San Francisco has come out with various research studies that do indicate that we have had a positive benefit on the community and not just raising education for hepatitis B, but also encouraging people to get screened and vaccinated. There are other studies currently in the works to find out whether or not we've changed the primary care physicians' behavior in terms of encouraging their patients to get screened and vaccinated as well. But everything points to yes. We've been acknowledged by the CDC as a model to be replicated across the nation. We have over 15 chapters as well throughout the nation, one of which recently popped up was Hawaii Hep Free, which also works on hepatitis C. That's based off of the same model of our organization.
I would imagine we track the number of seroconversions each year.
The Department of Public Health does, yes.
And do we know what the numbers are?
The most recent report, no.
But we know they're going down as a result
Yes.
of these tens of thousands of screenings.
I think it is going. Well, I think what we want to do is look at the cancer rate, and so cancer rate in San Francisco has been going down in the last 10 years. I'd like to attribute it to SF Hep B free.
Sure.
So we'll take credit for that. But I think in terms of getting to zero, which is our goal for San Francisco to be a Hep B free city, it's probably, I mean, is it attainable? Probably not, because I think because we are an entry for new immigrants, right? So it makes it very difficult if you're coming from a third world country that doesn't have the infrastructure to take care of hepatitis B, and they come here, you know, we're always going to have that on our record. But we want to make sure they get the right care and follow-up so they don't develop cancer.
And I would imagine, and I know I've been a number of the rallies that you've had for Hep B free here in San Francisco. The messages are, number one, get tested. Everyone needs to get tested. You need to know your status. And then you need to know how to keep your partner safe.
Right. So with SF Hep B free, what we concentrate on is, one is awareness and education. Two is to be screened, because that's an important part. And then to find out if you need to be vaccinated. And if you're chronically infected, we want to make sure you have good linkage to care so you can be followed.
Right.
So those are our 4 points or steps in terms of Hep B free.
Right.
And actually, one of the things that we're currently developing is a linkage to care program where we're going to be able to provide more direct services to individuals that either have general questions about hepatitis B, whether they just want to ask some random question, get some facts, or if they themselves will be at risk. If they've been screened and found out that they need to get vaccinated, we can help direct them to those appropriate services. And if they need to get on a treatment plan, if they're chronically infected, then we can inform them that they should be following up with their primary care physicians. So we are on the front now of being able to provide more direct services so that those individuals that have been serviced in the past or just want more general information can have that service that they need.
And you have your annual gala coming up?
Yes, we do. Yes, we do.
The Intercontinental,
Wednesday,
right?
October 19th. Yes.
October 19th. Everyone should know that. All right. Thank you.
Thank you.
Thank you, Doctor.
Okay, thank you, Senator Leno. I have a few questions I wanted to just follow up on, and so I guess the first one is that I know you mentioned the main modes of transmission. However, I believe before the vaccine, it was estimated approximately 10,000 children a year caught hepatitis B who were born of Hep B negative mothers. But then became Hep B positive before they were age 10. So presumption is they weren't using drugs or engaging in sex or something. Can you perhaps speak to, so I know and that's what some people have said, well, gee, if my kid isn't having sex and they're not using IV drugs like those people, then I don't need to worry about prevention and vaccination. So can you speak to that?
So on fast facts for Hep B, so it's interesting that, so hepatitis B can be spread from human bites because you break the skin and it can penetrate. If you understand, our most vulnerable parts of our body is our eyes, nose, and mouth. Because of the mucous membranes. But our skin acts as a protective layer. So if there are human bites, possibly, you can transmit the virus itself. Of course, sharing needles, but hopefully kids don't do that. But any cuts or nicks, it can spread. So as we said, it's 100 times more virulent than the HIV virus. So if somebody has a sore, I know among Asians, we always have family dinners, right, where we share our food, we share our serving utensils, or not our serving utensils, but we're picking at food and we're feeding it to our youth, and so that's one way that it can be spread. So a lot is about education. We want to make sure that people understand that hepatitis B is not spread by kissing, right? It's not spread by coughing or sneezing or hugging or eating prepared food by infected people. So these are the things we want to make sure people get educated about, because there is a cultural stigma about hepatitis B, especially when you come from an area that's high endemic.
And also to that point, within the first 5 years of birth, the immune systems are still developing. They're still compromised to a degree. So, carrying on from Dr. Fong's point, that could put them at higher risk for contracting it. Yes.
And as you've been doing your work, educating the community and going around, you said encouraging people to both get screened and then also vaccinated if that's something that would benefit them. Are you experiencing any resistance as you're going around in terms of vaccination?
Well, I can give an example recently of some screening efforts that we've done out in the community. And this is actually something that holds true from my work back in Santa Clara County, too, on Hep B, where a lot of individuals were stating, well, oh, I feel perfectly fine. It's not something I need to worry about. I'm in good health. I exercise regularly and all this. And that's one of the issues with hepatitis B. It's a silent killer. You know, there aren't typically any symptoms. So when we're encouraging people to get screened, even, that's where the challenge starts. But after they get screened, it makes it a little bit easier to make that next step. But culturally, I mean, depending on which community you're working with, too, there are those independent barriers that they have. So it has been a challenge to break through them, but we have been learning to work with what we've been given. So, yes.
Wonderful. And then finally, I know that Senator Leno posed the question about progress, and actually I believe there was a paper that was published sometime in the past year that actually said that it's possible to eliminate hepatitis B from the globe. And I think, was it the next, I forgot exactly how long, was it 20 or 30 years or something?
20 years, yes.
Yeah. So what, perhaps, do you want to comment on, I don't know if you had a chance to, you ran across the paper before or not, whether to comment on your thoughts as you're trying to make San Francisco Hep B. I have to imagine from Sacramento, but you know, our goals in trying to eliminate hepatitis B from, of course, not only this city, but the state and our country and around the world. What you want to reflect on the opportunity to make that happen?
So one of our founders, Sam So, at the Asian Liver Center, Dr. So, he's at Stanford. So he has a lot of programs in China that he's doing. So one of the programs he has that I think is very effective is the catch-up vaccine. So I forgot which drug company, but I think it was Barack Bloomberg who discovered the hepatitis B virus. He allowed China to make the Hep B vaccine, and so they're able to produce it for $1, or the cost is $1. So the government is able to develop all these vaccines, and they are doing the vaccinations on the children, so they'll be protected for life. So currently now it's about changing the stigma and the culture about discriminating against hepatitis B, that if you can prove their low risks for transmission, they can still function in society. But I think it's the follow-up, and I think for China, I mean, having a country of over 1 billion people, and I'm sure, I mean, we see a shortage of primary care physicians in the States. I'm sure in China it's even greater. But I think that's where it has to be worldwide, is to ensure that there are enough physicians around to follow up, because the linkage of care is so important. Can it happen? I mean, we got rid of smallpox, so why not Hep B?
Great. Excellent. Well, I think we'll probably have some opportunity to actually pose some more questions in general, because we're going to be hearing about HPV next in our 5th session. So, but I want to thank you both, and look forward to actually further discussion in the 5th panel. So thank you so much for being here. Thank you. So next, I'd like to welcome up Sabrina Fernandez, who is Dr. Fernandez, who's a clinical assistant professor of pediatrics, who's going to be addressing HPV and cervical cancer risk, particularly, hopefully with also a focus on the API population. Welcome, Dr. Fernandez.
Thank you. Let me pull up my presentation real quick. So my name is Sabrina Fernandez. I'm a pediatric primary care physician here at UCSF Benioff Children's Hospital. Also, I'm a board member of the San Francisco Immunization Coalition, and in case anyone is interested in that, please let me know, because we're really trying to promote immunizations here in San Francisco. So let's get everybody on the same page about what HPV is, because we have a pretty diverse audience, and I know that this presentation is being live streamed across the state. So HPV is human papillomavirus. It is the most common sexually transmitted disease. It is, like many sexually transmitted diseases, can be asymptomatic, and so you may not know that you have it. But there's good news, which is that your immune system, most of the time, actually fights off HPV. So the vast majority of people that get this very, very common infection are actually going to be fine. However, there's a small group of people that unfortunately will go on to have complications. And the most common of those are genital warts and cancer. Unfortunately, in otherwise healthy people, there's no way to tell in a room full of people if we all got exposed to HPV, who is that one person or two people that will go on to get complications in otherwise healthy people. So let's talk a little bit about the worldwide yearly HPV cancer burden. It's a lot of words, but basically, if you look at the triangle here, the vast majority of HPV-associated cancer is cervical cancer. So a little bit over 500,000 women across the globe every year are getting cervical cancer. If you look at the very top portion of the graph, or of this graphic, you'll also see that there are several other cancers that are associated with HPV. Anal cancer, penile cancer, and oropharyngeal cancer are also ones that can affect males in addition to females. And the oropharynx is the back of the base of the tongue as well as the tonsils. So let's look at just sort of our domestic cancer burden. In the US, about every year, there's 27,000 people that have HPV-associated cancer. And I think that when we talk about these big numbers, it's very difficult to put that in perspective because it's just a bunch of zeros and it's hard to imagine what 27,000 people look like. So said in another way, that's one person every 20 minutes of every day all year long. So already since we've been sitting here together, there's been 2 new diagnoses of HPV-associated cancer across the United States. Specifically for cervical cancer, it's about 11,000 women yearly that get cervical cancer diagnosis. And for genital warts, the numbers are much higher in the US, so closer to 360,000 people that get genital warts. So I like this graph because it shows that cervical cancer rates are actually declining, which is wonderful. So this is a graph that goes from 1999 to 2013. And you can see that the black line, which represents all races, that overall the cervical cancer rates in the United States are going down. So yay. In the blue line, you'll see the Asian Pacific Islander community, which actually has relatively sort of similar rates or maybe a little bit lower. Of note, the numbers that were given by Dr. Chen in the beginning were data from the 1990s, which in which Asian Pacific Islander community was much higher, as he had said, particularly among Vietnamese women. But one thing that I do take away from this graph, although in general it's good news, is that our numbers in our community are not going down at the same rate as other communities such as Blacks and Hispanics. So if you're diagnosed with cervical cancer as a woman now in 2016, your chances of being Asian are actually higher than they would have been in the late 90s. This is an interesting study that I found that was just published this year, looking at specifically cancer survival. So the end game of, who's actually getting fatalities from cervical cancer. And what they found was that although Asian American women, except Japanese and Korean women, had overall better survival, yay, they were older at the time of diagnosis. And so it perhaps points to less access to regular screening programs. So that leads right into what is cervical cancer screening. So this is the Pap test that women get. And the very basics that everyone should know is that women need to get a Pap smear starting at age 21 on a regular basis. This is a quick graphic of what they're looking for. So they take a gentle brush, brush the cervix, and then they look at the cells under the microscope. On the left, you'll see what looks like normal cervical cells, and on the right, those are cancerous cells. Their nucleus is large, it's dark, and the cells overall are larger, indicating proliferation. This is another study I found that was published in 2013, and it looked at just how well are we doing with cervical cancer screening. So how many of our people in our community are getting Pap tests? And unfortunately, it looked like Asian and Hispanic women, on the numbers that they found, had less chances of having gotten a Pap test in the last 3 years compared to Black and white women. So we're not accessing that regular screening program in your primary care world. So we're going to switch a little bit to HPV vaccination, so we'll get everybody on the same page about that. So starting in 2006, 10 years ago, the CDC put the HPV vaccine as a regular vaccination in the routine vaccine schedule. You vaccinate starting at age 11 to 12, and you get 3 doses over a 6-month period. So people often have to come back in for nursing visits or repeat physician's visits because at 11 or 12, in an otherwise healthy individual, you're just getting yearly visits. It's important also to note that the vaccine can be given as young as 9 years old and as old as 26 years old. So even though it's recommended at 11 or 12 in the sort of preteen ages, it can be given to young adults as well. One of the things that I often hear in my primary care practice from parents of these 11 and 12-year-old kids that are coming in is that there's time for that later. And we've talked a little bit about this, especially in regards to hepatitis B vaccine, that my kid's not going to be exposed. Why is this important? And I think there's several good arguments for that. So the first thing to let families know is that it's important to get the child vaccinated way before there's even chance of exposure. We know that as children age, their likelihood of having sex is going to go up. And so you want to get all 3 doses of the vaccine into the child way before exposure. And the second thing that's really interesting is that there's some data to suggest that early vaccination, or not even early vaccination, but on-time vaccination at 11 or 12, perhaps gives the child a better antibody response than if you had waited till age 16. So not only are you vaccinating way before the chances that the child could get anything, but the child is going to have a better, stronger immune response potentially at that age. I recently had a family ask me, what is the earliest age I can give my child the HPV vaccine? And the reason for that was that the mom had been diagnosed with cervical cancer. She was a healthy person in her 30s, and her kid was 2. Her little baby girl was 2. And she said, I want to get my child vaccinated as soon as possible because she understood the importance of strength in the immune system before you get exposed. So how are we doing in terms of vaccines? We looked at a little bit of graphs in previous presentations about this, but we're about 60% of girls across the nation who are getting vaccinated with HPV and 50% of boys. It's important to know that this is initiation of vaccine series. So as I said, it takes 3 doses to get to protection, and this is just data looking at 1 to 3 doses. So presumably the people that have started the vaccine series will finish, but it's important to know that it's sometimes hard to remember to come back for those visits to get your 2nd and your 3rd HPV vaccine if you're an otherwise healthy kid. In terms of vaccine safety, this is probably the #1 question that I get, and it's important to remember that over the last 10 years since we started giving this vaccine, this is year-old data, so at this point we probably have over 80 million people who have gotten the HPV vaccine in the last 10 years, which is a huge number of people. And so our experience with it as time goes on is getting better and better, and we're understanding more if there are any kind of serious vaccine safety concerns, which there have not been. Also, during pre-licensure clinical trials, so the way that they studied this vaccine before it got put into the regular vaccine schedule, were studied on tens of thousands of people at that time. So a huge number of people have been vaccinated, me included, and have done very well. In terms of vaccine effectiveness, it's exciting that we already have some really great data. So this is data published in 2014, but we've seen a 56% reduction in the prevalence of HPV strains 6, 11, 16, and 18. Those are the strains that were covered in the 2nd generation of the HPV vaccine. The 16 and 18 are the ones that cause cervical cancer, and 6 and 11 are the ones that cause genital warts. We've also seen a 36% reduction in genital warts in U.S. girls in the 15 to 19-year-old range. So we're already preventing disease in really pretty incredible numbers. As we had said, the HPV virus can be asymptomatic for a long time, especially when it comes to cancer. And so likely, because of the vaccination, those cancer rates for cervical cancer are going to continue to go down, but will likely take longer to collect. This was a study that I looked at just published last year that was a focus group study among Korean American women. So they asked 26 women, what do you know about the vaccine? Have you been vaccinated, and what do you know about HPV and how it relates to cervical cancer? So the good news is that this cohort that was interviewed were generally positive about HPV vaccine. They thought it was a good idea, but they also lacked awareness and knowledge about HPV and how it relates to cancer. And what they specifically wanted was culturally tailored HPV education programs, and I thought this was well worded. They also wanted information sharing by a trustworthy source in a comfortable environment. So that begs the question, what is a comfortable environment for Korean American women? And I think we can talk about that a little bit more, but how do we make the most comfortable environment for discussing these pretty serious diseases and make sure that they feel the most confident and comfortable in getting them or their child vaccinated? So how are we doing specifically with our community? This is data that's from a few years ago, and we're going to split it up by age group. So let's first start looking at the 13 to 17-year-old age group in boys and girls. So for boys, Asians, which are on the leftmost bar, are doing pretty well, a little bit above or slightly below sort of an average if you look at the other races. For girls, the overall vaccination initiation rate is higher, as we know, and for the Asian community, it's about similar. However, it's interesting that the older groups, so women ages 19 through 26, actually have a different sort of bar graph, with Asians being the lowest race with HPV vaccine initiation. And then the data that I found didn't separate it out for men, but in general, men ages 19 through 26 have a much lower vaccine rate. This is an article. You can tell that I really like articles, so I pretty much looked at every single one here. But this was another one that I really, really liked. This was an abstract published just last year, and I like it because it interviewed a lot of people. So all the articles that I'd seen published so far were 20, 25 people, small cohorts, and small sample size. This was a study that interviewed over 2,000 women in the particular age group that we were just talking about, with Asians being at the lowest rate of vaccine initiation. So this is women at a large public university in the Midwest. Large number of sample size. They asked them, what do you know about the HPV vaccine, and have you been vaccinated? What they found was that Asian American Pacific Islander women had a lower rate of vaccination compared to white women, with a pretty significant number, so 38% compared to 60%. Additionally, they had lower vaccine literacy, so they didn't understand what the vaccine was for or how it related, perhaps, to cervical cancer. And significant factors that were related to getting vaccinated, including knowing someone who had had cancer. So I think that there's a lot of power in telling stories and reducing stigma about all of these diseases, because if you know someone personally that has gone through it, you're more likely to protect yourselves and your family. This is, I think, maybe the last study that I'm going to show you, but it was published just this year about it was looking at similar things in Hawaiians, and it specifically asked parents what they knew about the vaccine and about cervical cancer. And they found several sort of recurring themes, but this one I thought was spoke to me a little bit. So what they wanted in their educational materials was local faces and testimonials, a clear immunization chart, and something that addresses barriers to vaccines. So folks in this study, I think it was 20 parents, wanted to see educational materials with people that looked like them and those stories that were from people in their community. This is just a graphic that I found on the CDC website, which is a clear example of how we can sort of engage our community better and make materials that are sort of more friendly. So our end game is how to eliminate disease and death in our community. And we're going to do that in 3 ways: prevention, early screening and detection, and treatment. And the main things we've talked about today is vaccination, regular pap smears, and an effective medical home. And so I came up with a lot of ideas as I was sort of brainstorming this ideas, and I'll just highlight a few here. So certainly addressing language barriers in online and printed materials is important. Perhaps focusing on specific populations. How do women get HPV? They have sex with men, so maybe we should be vaccinating our men better than we are now. Do we need to have a better and more engaged medical community? There's no HPV-free SF group. Maybe we need to take the baton. How can we have more data-driven improvement? I found plenty of studies, but like I said, the sample sizes were relatively small. And how can we get more data to know exactly what our community needs and wants? And so just to sort of get some take-home points, HPV is the most common STD, and in some people it can cause cancer, especially cervical cancer in women, and genital warts. HPV should be thought of as cancer prevention. So just like the hepatitis B vaccine, HPV is cancer prevention. And like Dr. Chen said in the beginning, that is probably the most effective way that a physician can talk to a family about HPV, is that we are trying to prevent your child from getting cancer or giving their future partners cancer. And that there are lots of things that we can do specifically to prevent, detect, and treat HPV disease in our community. Thank you very much for your time.
Hey, thank you. Thank you so very much. Senator Leno, did you have any questions?
I do.
Senator Leno.
Thank you, Doctor.
Yeah.
Great presentation.
Yeah.
You had a slide that showed that we're up to about 60% of women and 50% of men who are vaccinated against HPV.
Mm-hmm.
Is there probably a ceiling that will hit just because this becomes culturally sensitive? I remember when we were debating this in the legislature, we had Republican colleagues who said that this is acknowledging behavior we don't want to promote, and that there could be an unintended consequence of giving license to
I'm so glad you're
sexual
asking
freedoms
this question.
that some people would want to discourage. So I wonder, is there just a certain percentage that we can't get beyond? And given my memory of the debates that we had with regard to Dr. Pan's vaccination bill, is this infection of a different variety from measles, mumps, and others that we don't need to be at 95% because of the herd effect? How does that play into this number?
Yeah, so I'll make a few comments because I think you asked a few questions. So the first thing that I want to address, and I swear I did not plant this guy, but there is very clear data that shows that the HPV vaccine does not increase promiscuity among young children. So that is a big one, like, oh boy, I'm giving this vaccine for an STD, but is that going to make my kid feel all free and go out? No. They're going to be fine, and they're not going to have sex earlier than they would have anyway. So there's clear data to support that.
And on that point, I'm sorry to interrupt, but
sure.
We've had some debates within the HIV community about PrEP, which can be taken orally and can prevent infection, but one person in the community actually called it a party drug. It's going to give license to people to go out and behave in unsafe fashion, but in fact there's been very little demonstration of that either, so it agrees with what you've just said.
Yeah, totally. In terms of the second question you had sort of about a ceiling, so if you compare HPV vaccine initiation rates, so the numbers that I was showing you, it's important to remember those are just vaccine initiation, and folks that have gotten one out of the three necessary, one or more out of the three necessary shots.
You did mention that.
And so there probably is a ceiling, and it's would be hard to get to 100% vaccination for every single vaccine, and for good reason. So for specific vaccines that are live, for example, they can't be given to people with immunocompromised status or those folks who are on chemotherapy or those sorts of medicines. So probably we wouldn't be able to get to 100% because there's people that have sensitivity to the vaccine itself or a component of the vaccine. But if you look at the numbers for the other sort of vaccines that are in the part of the schedule, like tetanus, diphtheria, pertussis, MMR, those numbers are much higher. So they're getting around the 80s to 90s in San Francisco, the last time I looked at the kindergarten data, whereas the HPV vaccine numbers are 50 to 60. And I think that that might just have to do with it being the new kid on the block. Less that it's going to increase promiscuity, but more just that people don't know about it as much because it's only been in the regular vaccine series for 10 years.
And do we need to hit those higher numbers for it to be effective, or these are different kinds of infections?
Yeah, so I'm not sure. So with every vaccine and with every disease, the number to hit for herd immunity, as you know, is different. So it depends on the virulence of the vaccine or the virulence of the virus, the mode of transmission, and you have to be a much smarter statistician and epidemiologist than me to understand exactly how that number is created. I'm not sure what the herd immunity number for HPV is, but given that it's the most common STD, I imagine that you have to get much higher than we are getting now.
And then just a follow-up question. You'd mentioned the 3 doses that are necessary. Must they be done within a certain period of time? So if I bring my child in for the first and then 2 years later realize, do you have to start over?
Great question.
And what is the term?
Yeah, so there is no point at which you have to restart the vaccine series. So if you moved away or were busy or forgot to bring your kid in and then came back for the second dose 2 years later, you don't have to restart. However, the vaccine was studied with the most people and during pre-licensure clinical trials with that specific schedule in mind.
And
so
what is the schedule again? Is it 2 months, 3 months?
So between the first and second dose, there should be 1 to 2 months, and between the first and third dose, there should be 6 months.
Got it.
So people usually come back for nursing visits in my clinic to get their second and third shots.
Thank you.
Of course.
So again, thank you so much for presenting, and also look forward to a more general discussion with you and the panelists from on hepatitis B.
Sure.
But more specifically to HPV, it's one question is that in terms of the you mentioned that Dr. Moon's presentation, because we were looking at the API community, and I know that in NCART they talk about how HPV actually specifically for certain API subgroups, and you did a pretty extensive look at the literature presentation in your presentation. Do we know if any of the subgroups have changed? Are we tracking that data in terms of cervical cancer rates or infection rates when it comes to, so he's presented, you mentioned that the data was a little older, the increased risk in the Vietnamese population. Yeah.
So I actually tried to find that data separated by Asian subtype, and I couldn't find it. The data that I could find just was Asian Americans altogether. And I apologize, I misspoke Dr. Moon's name. But anyway, I couldn't find that data, whether or not the Vietnamese population was still at a high number. I'm not sure.
Okay. All right. So I think that in terms of, because as you mentioned, in terms of interventions and developing materials and so forth, I know that this year we just passed a bill that was signed into law looking at disaggregating data in the API community. Hopefully, I don't know if that ties into the cancer registry or not, as we're looking at cervical cancer. Hopefully that can provide us some insights as to where we can target our resources. I mean, I think we try to target as many people as we can, but where we target our resources toward doing education and, if we talk about in-language and other types of approaches to addressing that.
Absolutely.
Thank you. All right. So I think with that, I know you covered a lot of ground also with Senator Leno's questions.
Sure.
And so I think maybe what we'll do is we'll bring up our hepatitis, Dr. Fong and Kolchak, and we're going to have a more general discussion about strategies, prevention, screening, and treatment. So if you want to come up, and you stay up. So do we need to bring up another chair here?
Probably.
Yes, I think so. So I think what we want to do here is sort of have a discussion across the panel. But maybe maybe I'll just lead off to just kick this off because all of you made reference to stigma and as being a barrier to your efforts to reduce these cancers and these infections. So perhaps can you speak to what are some strategies and what are some of the stigmas that you see encountering in terms of both hepatitis B and HPV, and particularly in the API community, and your thoughts about how we overcome that? How do we get that discussion going, both in the public and perhaps also, within the homes of people, as they're talking about these particular conditions, as we try to spread the word. So I'll just leave that up, and someone wants to take that ball and start running with it, and then we'll get a little back and forth there.
So I think with SF Hep B Free, when we first started, it was about getting awareness. So our first campaign we had was about being a hero, right? So we want to encourage people to be hero, talk about hepatitis B.
With boots and capes.
With boots and capes. We still have the boots and capes. And also to have them discuss it with their parents and grandparents. So basically that'll help destigmatize it a little. So initially when we started, we thought, we could go into businesses and talk about hepatitis B. But when we did it, it was like, no, we don't want to discuss it yet. But I think because we've been around for a while now, we've had the different campaigns, we had the 1 in 10. So I think it's easier to talk about it. So I think in terms of the HPV vaccine and hepatitis B, I think we just have to have that constant messaging out there so people see that it's out there and it's an everyday thing, and that eventually it'll be, okay, maybe we can discuss it more if it's in the public realm more.
One of the things that I can comment on in regards to approaching businesses, since we are working on this new business initiative now, we started our efforts in Chinatown in San Francisco over here. And one of the things that we learned very quickly was talking about cancer first thing in the morning when the businesses open up is a very bad idea. So we have to learn to work when we discover new things like this. But again, gaining access seemed to be a lot easier because they have already heard about it. Versus not knowing anything about it, and we're going in and trying to talk to them and convince them to get screened and vaccinated for something. So it's just been an evolution, work in progress type of thing.
So I think I'll just make a couple of comments. I think just when we approach the conversation, when we're talking to families and that when we're talking to community members, to normalize as much as possible that this is what we talk about with everybody. It's not that we're worried that your child is going to do XYZ and get themselves in trouble. This is something that we recommend across the board. I also really, really liked the Superman style shirts, and I remember watching I like the Eurythmics, and so I remember watching Annie Lennox on stage at some point on TV, and she had a shirt that said HIV positive, and I've seen similar shirts where it says HIV positive, and then the back says, do you know your status? And so having people like, the folks that you work with that are brave enough to say that this is an issue that I deal with, and that it's important to know what your status is, I think is really wonderful.
On that point.
On Annie Lennox? No.
Areas where HIV and Hep B intersect in terms of public education, awareness, screening, testing, treatment, early interventions, all of that. There's probably much to be learned from HIV's experience. One of the areas that, and you've put your finger on it, Doctor, is knowing your status and actually public conversations about couples who may be serocompatible or not, and how to keep the negative partner negative, how we keep our negative communities negative, and at the same time doing it in a sex-positive message. Are these approaches happening with regard to HPV and Hep B?
No. So among the, because we mostly work in the Asian community, and so sex is not, that open, but I know everyone does it. But I think it's about getting over the stigma about hepatitis B.
You need some more drag queens.
Yes, we do.
I would point out that the
But I think one of the largest barriers for the cultural stigma is trust.
Yes.
Yeah. So if you're an immigrant coming from China or coming from another country, it's about, do you have that much trust in the government? When we first initially started with SF Hep B Free, we went to City College and we went to the ESL classes, right? Those were the easiest. New immigrants were there. And so we did the education about hepatitis B, we did the screenings. And so and we found a few people who were chronically infected. And we said, we have physicians who are willing to see you, but they didn't want to go because I learned this too. It was about, I could lose my green card. So my wife, who's an attorney who did immigrations, I had her come in language, explain to them that, you can be hepatitis B and you won't be kicked out of the country, but they're not going to trust that. They're not going to trust what you have to say in terms of that green card because it's so important to them.
Sure.
And they don't want to do anything that jeopardized it because they know back in their country if you had hepatitis B, you were kicked out of school, you were, kicked off your job.
So the stakes are very high.
Stakes were very high, and so I think breaking down that trust or developing the trust for them is very important.
Or these are added complications I hadn't thought of before.
Yeah. Neither have I. I mean, I'm a third-generation American, so basically I'm American. So we can't. I didn't understand. I go, what's the big deal? You just get tested, go see your doctor, but it's not like that.
Right. Do we have comparable numbers for percentages of populations vaccinated for Hep B as Dr. Fernandez did with regard to HPV?
No, because again, it's finding that denominator number. That's probably very difficult now. A lot of the adults who are getting vaccinated is more of a catch-up vaccine. But I think if you look at the children's vaccine, it's probably much easier to get them. Because I noticed with the HPV, the younger you are, the higher the percentage, because you can float it in with the other vaccines. And so it's interesting that I didn't know. But HPV, I mean, with Hep B is a 0, 1, 6 months. So I think giving those both together is a good way to have it increase your numbers.
So I guess in terms of stigma, actually, when it comes to the HPV vaccine, I mean, what we hear commonly with both is that on one hand, we're trying to send the message that these vaccines prevent cancer, right? But because both of these can be, they're not only, but you have to be, they can be transmitted sexually. People hear sex first. How do we get? And I know that the point was made is that actually this has nothing to do with sex. Actually, it's about preventing cancer, and so I guess what are your thoughts about how do we get past that part of the conversation where people, and actually for HPV, I think one of the challenges is that we are administering it, and I can understand the reasons why perhaps they've targeted in terms of approving the vaccine for essentially those prepubescent years, but those are the years when basically, parents are getting a little anxious about that their child's growing up, right? And there's actually, when you're talking about 12, I mean, that is when the early, for many children, they're actually becoming young men and women. They're they're starting to already experience some of the physical changes. Think about when average menarche is, telarche, et cetera. So you're already combining that. The discussion about the vaccine with the physical changes of puberty happening simultaneously. I guess the challenge we had with MMR is that you gave the MMR at the same time people develop developmental symptoms. Now we're going to administer a vaccine that we say is about preventing cancer, but it's also something that can be transmitted sexually. We're giving it now during puberty. So the thoughts about how we overcome that in our community.
Absolutely. So I think that anyone who's a parent can probably relate, if they have an older child, that once the doctor starts having those conversations with your child about puberty and having their first period and all this kind of stuff, it's a little bit hair-raising, because you see the parent just imagine the baby pictures in their brains as you're going through this. And so I think, at least in my practice, it's important for people to know that it's an STD, but I keep going back to the fact that this is cancer prevention, and that although there's no chance for the child to be exposed in the near future, that given that it's the most common STD, it's likely that they will get exposed in the future. And if there's anything that you can do to prevent cancer in your child, that you should do it now. I think one of the things that we may do in terms of sort of vaccine promotion is actually look towards vaccinating people that are still eligible for the vaccine but are a little bit older. So, 19, 20, 21-year-olds, college students, specifically women who are eligible for the vaccine, may not have known what it was, or may have been playing on their cell phone while their parent was having this discussion and not really paying attention about what it is. And so perhaps when that 18-year-old goes into student health at City College and needs to get treated for whatever XYZ, that we talk about vaccinations at that point, because that may not be on their radar.
Are there any side effects to either of these vaccinations?
So for HPV specifically, common ones include, just a little bit of pain at the injection site. That's pretty common to all vaccines. But an important one that's significant to HPV is a syncope. So people can feel dizzy and even faint after getting the vaccine.
Immediately after?
Immediately after. So it's routine protocol to keep the child in the physician's office for 15 minutes after receiving the vaccine. This is, it's important also to note that this is not a serious side effect. In the thousands of patients that I've vaccinated with HPV in my clinic, I've seen this 3 times, and they usually need to lay down and drink some apple juice and hadn't had anything to drink or eat before they got their vaccine at 11 a.m.
Sure.
and they need to just lay down for a little while and then feel better.
It passes.
Exactly. I think that if you Google HPV side effects, however, you'll get plenty of scary information. And I feel for families, because this is, how do you get information in these days? Is you go to Google. And there's power in testimonials, which is a big sort of take-home point that I was trying to make before, is that people's stories are very powerful. And the main story that you don't Google it, but now you're all going to want to. But anyway, it's important to know that people's stories are real, and that they pay attention to it, and that data doesn't speak to people the way stories do. So I can sit up here and show you the numbers, and we've vaccinated a bajillion people, and they're all fine. But if you hear from your neighbor that their child had some awful reaction, that's more telling than it is to show you numbers. And so, anyway, I think that there's power in testimonials, but in general, the vaccine is incredibly safe.
With hepatitis B, I'm not sure if there are the side effects, but again, I haven't seen them in all the shots that I've given, other than the usual pain and the psychosomatic passing out with the needle.
But nausea, headaches, nothing like that?
Nothing lingers.
Yes.
Yeah. The main side effects that I have actually seen is just the common ones that we're talking about. Pain at the injection site, fevers, which is actually pretty uncommon with Hep B compared to some of the other vaccines, and fussiness, especially since it's an infant series. Alternatively, babies can get a little sleepy, but that's normal too.
Sure. Okay.
Are there particular, and you touched on it in your presentations, but in terms of for the API population in terms of particular issues that may be unique to either the API population or subgroups of the API population in terms of trying to get your message out, that may not, so in terms of if you targeting the message, are there particular issues that have that seem to be, I would say, unique to, but more of a concern among either the API population or API subgroups in your efforts to talk about screening, prevention, screening, and treatment of both Hep B and HPV?
I think that there isn't anything that I can think of other than the normal things that we think of as barriers to sort of access and screening and treatment, which are sort of linguistic barriers. I don't think there's been at this point any studies, at least that I could find, about specific cultural barriers, other than that people want information in a sort of language that they can understand, with faces that they are familiar to them, and with testimonials from people in their community. And so I'm not sure if there's any specific ones for Hep B.
Well, we haven't found any, but I liked your slide up there where you talked about, culturally tailoring the information, which is very important. And of course, that's in language. And if it deals with the different dialects, and if you're giving a verbal talk, then that's important also. And the trusting the source. So I think it's important that not so much to have an outside person come in, but if we can train the trainers within the communities, and have them be able to go into the community to give the talks. I think you develop that trust there. And then the comfortable environment. I thought that was I never even thought of that till now, but a doctor's office is not a comfortable environment. So I think identifying a place where the patient feels comfortable receiving the information is important. So I think that's something I'm going to look into to make sure if somehow we can make this less institutional and more normal. So I think those are points that I'm going to look back when we go back into our communities, how we can improve on that.
So just to follow up on that, I guess there may not be any studies yet. Maybe someone will do one, but do you see an opportunity to then talk to members of the community about where would be a comfortable environment? You said, the doctor's office, is that going to be, is it, people talk about, the African American community, they may talk in barbershops or beauty salons, or in other vettings, other situations. So I don't know if people have tried to have conversations with people about, well, where do you want to get, where do you get your trusted information, right? We mentioned Google, someone's going to look it online, but is it going to be at a, what kind of gathering or what kind of location is someplace that people feel like they can let their guard down a little bit and have a conversation and figure out where, a conversation that they feel comfortable with, where that trust can be built.
So I think in terms of sort of making it the most comfortable environment possible, I think it's important for doctors, and if there's any medical students in the audience, to know that that families hear what you say, and that you are probably one of the most trusted sources for families when they are going to try to understand vaccine and importance of vaccines. I think that the sort of environment is also important to think about, and as it relates to specifically the medical home. So a person is going to feel a lot more comfortable if they've known the doctor for 11 years. The doctor was around when they were a baby. They've seen them multiple times and have trusted their medical opinions. So I think it goes back to access of a primary care medical home, and really identifying that pediatrician's office as a comfortable place to be, and reducing any barriers that could be sort of off-putting. So making sure that you have translators available, making sure that you're promoting diversity within your medical staff and your physician staff, so that if you have the ability to speak to the patient in their own language, that you're doing it, that they come directly from that community. And so there's plenty of things I think that we could focus on, but I think just there are simple steps to try to promote the medical home and make that the most comfortable place for people.
And maybe just to follow up, I see that we have members of the media here. Perhaps what's the role the media can play in communicating these types of messages? I don't know your experience with Hep B Free, with working with the media, and again about hepatitis. You know, you say you pull up something on Google, you see all this sort of stuff. So the role of the media in actually communicating both, including media and language. Where do you see the role of the media in helping spread information and the message about what people need to do to stay safe and healthy from these diseases?
Sure. Well, this again touches on that whole stigma point, and getting screened for hepatitis B doesn't mean that you're wishing it upon yourself. That means that you're taking the step to prevent hepatitis B and liver cancer, right? It's not just you that suffers, it's your whole family. And one of the stories that I know you're familiar with is Sean Lopez's, who lost her brother at the age of 30 to stage 4 liver cancer induced by hepatitis B. Right? The family didn't look at that as an issue that they needed to discuss, that they needed to take care of, and a life was lost. And it wasn't just one person that suffered, it was a whole family. Taking that step to get screened is very important, it's very vital, it's life-changing, and it's life-saving. I think that's the first thing that people need to recognize, that you're not the only person that suffers.
So with hepatitis B, SF Hep B Free, what we try to do is find a month. So October being Liver Month, I think it is. So it'd be great if the media can help us with PSAs, get the information out, right? I mean, you see NFL in October, right? Breast Month, right? All the football players are in pink. Well, how about if we also put them in the jade color for liver cancer, or even, I think cervix is green? Yeah. But anyways, if we can promote that among our PSAs. Everybody watches football or sports, and I think partnering with the sports team also helps because, they see their heroes, right? The heroes are unfortunately, always the athletes, but, if you can get them engaged in it, it's good. The media, I think, can report on it. I mean, it's good to get information out there, and, the first of the month say, okay, this is hepatitis month, or this is cervical cancer month. This is the data, this is the statistics on that. And so, again, as Dr. Fernandez said, it's about normalizing everything. So I think that's how the media can help.
I think there can just be more stories about people who have had cervical cancer or HPV-associated cancer, so that the numbers of stories when you go to Google have an equal representation of people that have had good experiences with vaccination and sad outcomes when they have not gotten vaccinated. And so I think that there's strength in stories.
I wanted to pick up on your last point. We've seen commercials that elicit fear from anti-tobacco efforts, where they've got people who have lost their voice box and speaking with a hole in their throat. Pretty gruesome images, but I would imagine those folks have done their focus groups and identified that that is a message that people pay attention to. I wonder if there might be an equivalency from either survivors or those who are currently dying from some of these diseases that could become a face that people would be a little shaken by and pay attention to.
I think that a powerful sort of message that I recently saw was just a young woman in my age group who had recently been been diagnosed with cervical cancer, and the this was a commercial for the pharmaceutical company, but was very effective, and it had sort of images of her getting younger and younger and younger, and eventually till 11-year-old, and the child looks at the camera and asks, "Mom, did you want to vaccinate me to prevent me from getting HPV later?" And
that
that's
is effective, yes.
A very effective sort of message, and that's what we're trying to get at. Is that's what we're trying to prevent. Early prevention is huge.
I have nothing to add. That was a good commercial.
That was a really good commercial. Got me on the heartstrings.
If there are no other questions, I don't know did you have any sort of final concluding remark you want to make as we wrap up this panel? We sort of covered a lot of ground, but.
I guess just thank you everyone for your attention and for coming.
I think, our work is not done here, right? I think Dr. Fernandez with her HPV and SF Hep-free with the hepatitis B, I think the work always continues. We need more support, especially from our local elected officials. But I think more importantly, it's about getting the support from our local Department of Public Health. In San Francisco, I think they do a wonderful job in supporting many programs. They're a big supporter of us, and I think we would not have been able to get off the ground if we did not have Department of Public Health, because we were able, like we said, we just blanketed every PCP about hepatitis B. When to screen, why to screen, gave them the algorithm to do it, and we got it in a DPH envelope. If it came from just SF Hep B free, I can guarantee you 99% will be in a circular file, but because it had the DPH logo, it forced physicians to have a second look, and so you got more eyes on it. And it's not like they don't know, but it's just been buried with so much other information that they have to deal with that it does bring it up several notches when they do read it and see it, to remind them. And it's important to have these messages go on. And so I think also having educational rounds such as this, or in hospitals, grand rounds, because I think when we first started, it was about getting hepatitis B in, and there'd be grand round every year. So, and I think that's being continued at all the hospitals, which is good.
Being open about your health status shouldn't be an opportunity for somebody to shame you for what you have. And I think that's a issue that all across the board, not just culturally specific, that is a concern amongst a lot of people. With the whole hepatitis B being chronically infected, or HPV, meaning that you're sexually active and it could be related to an STD. That's not the first thing that should be on people's minds. They shouldn't be shaming these people from having these diseases and being open about it. It's a matter of understanding what the issue is and what options are available. And I just wish that more people would take that into consideration. Thank you.
Well, thank you all
Yes,
for your presentations, and thank you all for being here. We're going to move to public comment, but just before we do that, when we set up this hearing, it was we were looking at what were some of the disproportionate killers of the API community, and I think when Dr. Moon opened up the discussion, we went and we were looking at the data, and interesting enough, it turned out it was disproportionately liver cancer, cervical cancer, stomach cancer impacting. So I appreciate the fact that he said that these are all preventable, and I appreciate the work that all of you are doing on the ground to prevent these deadly diseases. And it's great that we have a way to prevent these types of cancers. Hope we have more vaccines that can prevent more cancers. I mean, prevention is the best way to go about doing it. So I want to thank you all for your presentations, and thank you for taking your time. And I also want to thank Dr. Moon as well. I know he's left for making it here from Sacramento. So with that, I actually want to open it up for public testimony. If there's anyone who wants to make, we'll give you, so if anyone wants to make any public testimony, we have a microphone over there, and we'll give you 2 minutes to make, if you wish to make some remarks.
Okay.
Thank you.
This is on, right? Okay. So thank you so much for having this hearing. My name is Emily Hirio, and I am the Director of Hepatitis Policy for Project Inform, and I'm the chair of the California Hepatitis Alliance, which is a coalition of about 90 organizations around the state working to end Hep B and C. And I want to thank you, Senator Pan, for your ongoing leadership on health issues, and particularly vaccinations. CalHep is, of course, a big proponent of the Hep B vaccine. And thank you for holding this hearing and focusing on Hep B and part of it, and the impact in Asian and Pacific Islander communities. And I want to thank Senator Leno for your ongoing leadership, especially with budget issues and getting support for viral hepatitis-related items in the state budget, including $100,000 for hepatitis B vaccine to ensure that adults who are at risk are getting vaccinated in the state. I want to just note that some of the things that CalHep is deeply concerned about are lack of awareness about hepatitis B, both among the general population and in particular Asian and Pacific Islander communities that are so impacted, as well as among primary care clinicians. And San Francisco has a great model that really needs to be disseminated around the state, and there's some pockets that have done that, but we need to do more, and I think the legislature could have a lot of leadership in helping to promote that model. And we need more providers ensuring that their patients, and particularly their Asian and Pacific Islander patients, are screened and properly vaccinated. We're really concerned about the linkage to care issues, and I know Arkady mentioned that one of the things SF Hep B Free is working on is a linkage to care project. We believe that particularly immigrant communities need culturally competent education about the Affordable Care Act and the assistance in enrollment for Covered California and Medi-Cal, because that linkage is the vital link to getting your appropriate treatment for hepatitis B. And we believe there needs to be a better focus on the follow-up with sexual and household contacts of perinatal Hep B cases, that it's not just about the baby, but it's about the mom and the dad and any other potential household contacts, and make sure that the family receives appropriate screening and vaccination. And the last thing I want to note is that we really want to encourage the committee members to follow up with the State Department of Health and Human Services. The Adult Viral Hepatitis Prevention Coordinator did draft an updated plan to address viral hepatitis in the state, and that has been stuck in clearance for over 18 months. So CalHep would really like to know where that is and why it hasn't been approved. So that would be an ask from CalHep to you, to the committee members, is to ask the secretary, where is it and why has it been stuck in clearance for so long? This document is critical to ensuring California has a robust response to hepatitis B and hepatitis C prevention. And as was mentioned globally and nationally, the move is to look at elimination of viral hepatitis, and California really could be the leader. But we need, at basic, we need our document around adult preventive services for viral hepatitis. Thank you so much.
Great, thank you. Okay, any other, please.
I just want to echo that. So I'm Ann Singh. I'm professor of medicine from Stanford University. At Stanford, I lead a liver cancer working group, and I work very closely with stem cell. First, want to commend you for all of the work you have done, because really California has the highest liver cancer incidence and mortality in this country. But fortunately, in San Francisco, we have your model that we can actually use that for other population. One thing I feel is very important is the population subgroups, especially within the Asian American. We need more targeted prevention and focused effort. In terms of liver cancer, in most Asian subgroups, it is hepatitis B, but for one of the group that actually has the highest liver cancer incidence is Vietnamese, and for them is hepatitis C. So we need to look at these various subgroups and try to develop more sort of the subpopulation specific strategies for them. The other thing is the providers, and we did a survey among Stanford primary care physicians, and I hope this is not on the record, and actually a lot of our PCPs, they actually do not know how to treat their patients, and they actually, if they are not in the Asian community, maybe they are educated at Johns Hopkins or Harvard, they still actually have very limited information about how to treat Asian patients. And very recently, we also did a survey among our PCP on LDCT low dose screening, CT screening for lung cancer, and we have the similar response that they are very willing and eager to learn, but they did not have sufficient training. So I think if we can provide additional training for PCPs, that would be very helpful. One other thing is linkage to care. I feel in addition to screening right now, we need to focus more on how to have effective linkage to care, because these individuals, once they are screened and they are chronic carriers because they don't have symptoms. So many of them are lost to follow-up, and actually they are now under active liver cancer surveillance. So I think if we can develop an effective model for linkage to care, this will be very effective in lowering liver cancer mortality in our neighborhood or in California. So thank you so much for all of your work and really appreciate it.
Thank you. All right. Okay, seeing.
Can I respond to that?
Briefly, yes.
Briefly. So I think Kaiser actually has a very good program in which they develop in terms of HCC, hepatocellular carcinoma surveillance. So they've actually pooled all their chronically infected Hep B patients, and so they have a nurse practitioner who follows up with each and every single one of them. They have calls, they remind them to go see their doctor, they remind the doctors what they have to do. So I think the program that Kaiser set up for hepatitis B and liver cancer is one that can be modeled in other institutions.
Right. Seeing no one else at the microphone, I just want to again thank all the presenters for you taking the time and presenting the information and sharing your information and hoping to get the word out. I really appreciate, again, figuring out what we can do to not only just reduce health disparities in the API population, but also, of course, reduce the disease burden overall among all Californians as well, and figure out what we can do to particularly help out our API communities. I also want to thank Senator Leno for being here. I don't know whether this will be our last hearing together in the Senate.
Never over till it's over.
Yeah, it's never over till it's over. But I do on this occasion do have to say that Senator Leno, as we even saw in the presentations, is a tremendous leader for the API community as well as many other communities as well. And I've admired you before I ever got to the legislature, your leadership, and certainly just coming to the legislature has only increased my admiration for your commitment to the people of California and your leadership. So so I want to thank you so much for taking your time being here, but also thank you for your leadership in the state Senate. And we're going to miss you tremendously, but I'm sure we'll keep picking your brain afterwards as well. So with that, again, I want to thank everyone for taking your time to be here. And with that, this select committee hearing is adjourned. Thank you.
Thank you for the kind words.